Hello everybody, my presentation is on pineal tumors. I'm Dr. Lombardi Giuseppe. I'm a medical oncologist working at Veneto Institute of Oncology in Padua, Italy. This is my disclosure. So, what are pineal tumors? We know that tumors of the pineal region are rare neoplasms, accounting for about 1% of all intracranial tumors in adults, while they are more common in pediatric population, accounting for about 3–8% of all intracranial tumor. Among pineal region tumors, we have germ cell tumors, about 50–60% of all of these tumors. Pineal parenchymal tumors, about 30% of this tumor, and we can have also other rare tumors such as gliomas, embryonal tumors, so meningiomas, or also metastases from other type of tumors. However, very important, in this area we can have also non-neoplastic lesions such as pineal cysts or vascular malformations. According to the last WHO classification of brain tumor, in pineal tumors we have 5 distinct specific tumors, and among these we have also a new entity called desmoplastic myxoid tumor of the pineal region, SMARCB1 mutant. In the last year, using DNA methylation profile, we can obtain a better diagnosis of this tumor, and this tumor can be further subtyped using DNA methylation profile in specific subtypes. We can move on to pineocytoma. This tumor accounting for about 20–25% of all pineal tumors. It is a well-differentiated pineal parenchymal tumor, classified as a grade 1 tumor, and it is characterized by pineocytomatous rosettes at histology. It's a typically tumor found in adults with a median age at onset of 43 years. The prognosis is very good, with a 5-year overall survival rate of 91%. And the surgery alone is the gold standard treatment for this tumor. Radiation therapy can be used in case of recurrent or inoperable tumor. Pineoblastoma is a very aggressive and malignant embryonal tumor, closely related to PNETs. It is classified as grade 4 tumors, and on imaging it typically appeared as large and almost always associated with obstructive hydrocephalus and frequent CSF seeding at presentation. Typically found in infant or young patients, although about 70% of the cases can be involved in adults. Using DNA methylation profile, pineoblastoma can be subtyped in further specific subgroups with distinct clinical histological characteristic and specific prognosis. Indeed, we have four specific molecular subgroup of this tumor. MYRNA1 and MYRNA2 are characterized by MYRNA pathway process alteration, and a third group characterized by MYC-FOXR2 alteration, and the RB1 pineoblastoma group characterized by RB1 alteration, and it is associated with hereditary retinoblastoma. About prognosis, MYRNA2 and MYRNA1 are the best prognosis, especially MYRNA2, where we can see that at 5 years all patients are alive, while the worst prognosis is in RB1 and FOXR2 subgroups, with a 5-year overall survival rate range from 20 to 26%. About treatment for pineoblastoma, mostly derived from pediatric clinical trials, where this trial analyzed the use of radiochemotherapy treatment with high dose or standard dose chemotherapy, and however, chemotherapy protocols are based on various alkylating agents such as vincristine, etoposide, and also platinum agents such as cisplatinum, carboplatinum. The phase 3 trial, called the SIM-003, analyzed the patient with newly diagnosed CNS embryonal tumors. All patients were aged from 3 to 21 years, and these patients were classified as average risk when they had localized disease and no bulky residual disease, or high risk in presence of metastatic disease and or bulky residual disease. Patient with average risk received a lower dosage of craniospinal irradiation compared to high-risk patient. However, all patients were treated after craniospinal irradiation with 4 cycles of high-dose chemotherapy. And analyzing only the 40 pineoblastoma patients, the localized disease and gross total resection were associated with a longer overall survival. Another consensus study analyzed also patients included in another phase 3 trial called ACNS-0332, where pediatric patients with embryonal tumors were treated with standard craniospinal irradiation, but standard dose of chemotherapy. In the study, we can see that the type of radiation therapy, in particular craniospinal irradiation, and the MYRNA2 subgroup were associated with a longer progression-free survival and overall survival, analyzing only molecularly pineoblastoma. And another study published on Neuro-Oncology evaluating patients older than 4 years at diagnosis showed that the type of radiotherapy and was associated with a longer overall survival and progression-free survival, but not the type of chemotherapy, in particular there was not statistical difference in case of standard or high dose. And indeed, analyzing patients classified as Myrna2 pineoblastoma in the other paper published on ACTA Neuropathology some years ago, we can see that the prognosis is good regardless of the type of radiation therapy, the type of surgery, and the type of chemotherapy. And in particular, analyzing the two phase 3 trial, patients with Myrna1 and Myrna2 had the similar prognosis, and this led to evaluate the escalation of craniospinal irradiation and the use of standard dose chemotherapy. So we perform in the EURACAN group some recommendation for pinealoblastoma to use lower dosage of craniospinal irradiation in case of gross total resection, or not gross total resection but not metastatic disease, and but a higher dosage of craniospinal irradiation in case of metastatic disease. All cases should be followed by a standard chemotherapy and not chemotherapy. Moving on to papillary tumor of the pineal region, it is a very rare tumor characterized as grade 2-3 tumors based on mitotic count. The median age of one set is about 30 years. In this tumor, the recurrence is frequent, about 60% of local failure, while spinal dissemination is rare. Very important is that the most frequent molecular alteration is PTEN mutation. The prognosis is good with a 10-year overall survival rate of 72%. Radiation therapy, especially focal radiation therapy and chemotherapy, has been reported in various series, but their efficacy is still unclear. And indeed, two studies analyzed the impact of the therapy on progression-free survival and overall survival, in particular overall survival, and they show that surgery, only surgery, and can impact on prognosis, while chemotherapy and radiotherapy did not impact on overall survival. Recently it was published an important paper analyzing also the impact of molecular characteristic, especially DNA methylation profile, where an hypermethylated profile were associated with a short progression-free survival, and also an increased proliferative activity was associated with short progression-free an important case report showed that in this tumor, where we have PTEN alteration, the use of mTOR inhibitor such as everolimus could have an important impact on the response of this tumor. Indeed, we can see in this case report a good response to everolimus. And so recommendation for this tumor is to use focal radiation therapy only in case of no gross total resection or high proliferative index or relapse, and eventually to evaluate the use of mTOR inhibitor in case of PTEN alteration. Moving on to another tumor, pineal parenchymal tumor of intermediate differentiation. It is the most frequent tumor among pineal tumors, accounting for about 40-45% of the pineal tumors. It is classified as a grade 2-3 tumor. The median age of one set is 40 years, and in the 20% of the cases we can have metastasis at diagnosis. However, the 5-year overall survival rate is good, with a rate of 85%. Also in this tumor, the role of adjuvant therapy is clear. In a meta-analysis study were analyzed more than 100 patients with this tumor. We can see that more than half of these patients received a gross total or subtotal resection. Only 30% of these patients receive adjuvant radiation, and chemotherapy only in 20% of the cases. Very important is that the recurrence was observed in about 20% of the cases, especially as spinal or leptomeningeal diffusion. Female patient radiation therapy were associated with a better overall survival, while the use of chemotherapy and the extent of surgery did not. So our recommendation is to use focal radiation therapy only in case of no gross total resection, while in case of metastatic disease to use craniospinal irradiation in association with adjuvant chemotherapy in the same manner of blastoma. Finally, desmoplastic myxoid tumors SMARCB1 mutant. It is a new entity in the last classification. This tumor is characterized by the loss of expression of SMARCB1. It has a low proliferative index. The median age of this tumor is from 15 to 60 years. Interesting in this case both adolescents and adults. This is the imaging of our case treated at Padua hospital with this rare and new this is a recent paper analyzing 7 patients with this tumor. We can see that all these patients had loss of expression of SMARCB1 with a low rate of Ki67. And, however, all of these patients had no metastatic disease at diagnosis. It is an important characteristic of this tumor, and the prognosis is not bad. With a median follow-up of 4 years, we have 57% of patients alive. Also in this tumor, DNA methylation profile can improve diagnosis of tumor. So in conclusion, we can say that pineal tumors are heterogeneous primitive brain neoplasm with distinct clinical and molecular characteristics. Important is to use molecular analysis such as DNA methylation profile, because it could improve diagnosis, prognosis, and more personalized therapy. However, most data derive from pediatric trial of small case series in adults, and so it is very important of conducting the national studies or registry to better understand the natural evolution and maybe treatment, the best treatment for this tumor. Thank you very much for your attention.